gallbladder repetition now. Okay, it's a mundane topic, but this is an effort to let us know a few tricks and a few maneuvers which will really get us out of a lot of sticky situations. So gallbladder ultrasound is ultrasonically visible or visualized in almost all patients regardless of body habitus. Ultrasound is a rapid and repeatable anatomic assessment. It's the primary tool of GB investigation. The other tools are all there, but yes, gallbladder is the primary tool and it's a tool to stay. The evolution of ultrasound, this was it was a picture taken in my practice 1986. This is a picture taken in 2000, and you see the ocean of difference, and that is what ultrasound has been all about over the years. Okay, we are not going to go into this, except I have to stress that it's a minimum of 2 positions we have to examine the gallbladder. Every gallbladder we do has to be examined at minimum of 2 positions and a minimum of 2 planes, a longitudinal and transverse, definitely. Now that's the importance of harmonics. You see the gallbladder there, you see the gallbladder here. In harmonics, your contours appear much more clearer. There's a cleaning up of image which occurs more contrastier. Neck body fundus, GB neck, is located by the main hepatic fissure, echogenic wall thickness of 3 millimeters or lesser, and diameter of 5 centimeters or lesser. Phrygian cap is a normal variation. That's a Phrygian cap, which a little bit of sludge seen in 4% of cases. Main hepatic fissure. Gallstones, what are the hallmark? Acoustic shadow, highly echogenic surface, dependent position, mobility. So if all of them are there, 95% we are sure about gallstones. Gallstones are important because 42% of them go into chronic cholecystitis, 30% of them are indeed silent asymptomatic stones, 28% of them go into acute cholecystitis. So what, now here is a gallstone that is supine, the stone is in the neck, and that's upright, it falls down to the, that's a typical calculus. On real time, you will find these stones moving down. Look at that. Look at that stones moving down all the way. So that's stone mobility, and you can demonstrate it during the real-time examination. Now for shadowing we know is critical for any stone, be it a renal stone, be it a CBD stone or a GB stone. Use the highest frequency possible given the build of the patient. Narrow beam width. Scan in the center of the beam, and then if we use a right posterior oblique position, you can actually get the shadow onto the liver. Remember, just below the gallstone is pyloroduodenal gas. Pyloroduodenal gas gives rise to the dirty echos, isn't it? So if a shadow falls on these dirty echos, a very faint shadow might not be picked up. But if I do a RPO and look at get the liver in the aftermath of the gallbladder, the shadow will get through the liver and I can see it much better. Aggregate of small stones often shadow better than each one of those small stones individually. Reposition so that sometimes with the positional shift itself, the shadow comes in good. So we need to be liberal with the use of right posterior oblique, prone and upright positions for small stones, and examine the neck carefully for small stones. This is just a diagram which I've put. If you cut the stone partially with the ultrasound beam, no shadow. If you put your focus above the stone, and so that the stone is not at the Fresnel zone, but it's in the Fraunhofer zone. When it's not in the focal zone, you will not get shadowing. You will get only shadowing if you put the stone at the focal zone and put the entire diameter of the stone within the thickness of the beam width. Only then we will be able to produce a good shadow. Look at this. That's something in the gallbladder. But I'm not very convinced about the shadow. Is it sludge? Is it stone? There seems to be a shadow here. There doesn't seem to be a shadow there. But look at the focus. The focus is down there. So these stones are not at the focal zone. They are off the focus. Whereas when I push the focus upwards, this shadow becomes a lot better. So these are small things which can make our life easier. And again, this is the value of prone position. Now let's look at this. This was a difficult case. It was a 38-year-old and obese gentleman. The the visualization was very poor. I thought there was a stone over there, and I wanted more evidence or proof. So I put the patient prone and scanned the gallbladder in the prone position through the liver. When I did that, I expected to see one stone shifting, but actually I saw 1, 2, and maybe a third one as well, very faintly. So prone position can tell us a lot more information, especially in difficult cases. That's an RPO position. This is done to get the liver behind the gallbladder, not the pyloroduodenal gas, so that if there's a stone, small stone, the shadow of the stone will be seen better on a background of liver rather than pyloroduodenal gas. So we can do a RPO position to make our jobs easier. That's a floating stone, a small stone which is pure cholesterol, which is lighter than bile, and it's floating up there. That's a gallbladder sludge, tumefactive sludge, but within the sludge there is a stone, and that's the shadow of the stone. So we can get all patterns happening there. Differential diagnosis: gas, polyps, sludge balls, blood clot, pus aggregates, parasites, so on and so forth. This we saw. We will go on to acute cholecystitis. The most important sign is presence of gallstones and focal tenderness. The gallstones could be free or impacted. Focal tenderness. A dilated globular gallbladder, wall thickening, pericholecystic halo of fluid, and intraluminal turbidity may or may not be there. Focal tenderness and gallstones are the hallmarks, are a must for diagnosis of acute cholecystitis. So here is a gallbladder which is definitely dilated. There is a stone there sitting in the neck of the gallbladder. There is a shadow there, and when I put this patient upright, the stone is stuck in the neck, so it's impacted, and there is also a clear bile debris level. So this level is in this orientation, supine position, and the level changes when I put the patient into upright position, and this red arrow I have pressed on the fundus of the gallbladder under ultrasound control, and the patient says, that's exactly where you're hurting me. If I go a little that side or this side, the patient is comfortable. So that's sonographic. Murphy's sign, very important. Wall thickening may or may not be there. For example, the previous case we saw not much of wall thickening at all, but nevertheless I will still diagnose acute cholecystitis. Wall thickening, when it is, will be seen on both the anterior and posterior walls. The contents are turbid again, and that's the stone within. Variants of cholecystitis is important. Emphysematous cholecystitis, gangrenous, so on and so forth. That is emphysematous cholecystitis. We saw that in the previous presentation. That's the semicircular arrangement of the intramural gas. This is again another case of intramural gas with an intramural abscess, emphysematous cholecystitis over there, and that is perhaps an intramural or a pericolic abscess. Emphysematous infections are common in diabetics. Sometimes the whole gallbladder can become emphysematous. So when you scan the gallbladder area, you see a blob of gas. You do not know what is happening at all, and in those cases we can miss. It can be yet another condition where the gallbladder is not visible. A plain X-ray or CT will sort out this problem. Gangrenous cholecystitis. When do we suspect gangrene? Here is a gallbladder which shows you everything except the Murphy's sign. In gangrenous gallbladder, there is devitalization of tissues. The nerves no longer are irritated. A patient with pain says, no, his pain is gone. That's not good. That means the cholecystitis has turned gangrenous. The other important thing is irregular wall thickening, asymmetric wall thickening, fundic involvement, intramural abscesses, so on and so forth. So let's look at this particular case. The anterior wall is very thick. Posterior wall is not very thick. You have a stone there. You have debris there. All this is making me get very, very worried. It could be a gangrenous gallbladder. Again, look at this asymmetry. There's thickening here, thickening there, no thickening there, gangrenous. When you have intra-gallbladder membranes, that again means there is gangrene. The membranes have, the mucosa has sloughed off. It is floating in the gallbladder, and that's no good, and that's the impacted stone out there. Acalculous cholecystitis is a bugbear. At least when there's a stone and tenderness, you're sure of calculus cholecystitis. Acalculous cholecystitis, one of your main clues, namely gallstone, is not there. And therefore, you need to be very careful or very attentive, or you should be sensitized to the condition to pick it up. So it often happens in very, very devitalized patients. They could be aged, they could be postoperative, they could have intercurrent illnesses, there's no gallstones there, gallbladder is dilated, but what is very important is that there is pericholecystic inflammatory changes. To me, this helps me to say that yes, this gallbladder is the culprit. Although there's no stones, there is pericholecystic inflammation, and let us see how this looks. Now this is a gallbladder. There's no stone at all. But when I look at the peritoneum around, there is water logging, there is edema of the planes all around, and that tells me, yes, that is infiltrated, edematous peritoneum and fat, so on and so forth there. So therefore, that tells me that this gallbladder is pathological. And when you do a color Doppler, you have vascularity all the way around. There is an article which says that on color Doppler, you can see the vascularity only in the proximal 1/3 or 1/2, but never it goes all the way around. It goes all the way around in inflammation. Okay, that's the normal gallbladder, non-inflamed gallbladder, just to show you the vascularity coming up to the proximal 1/3 or 1/2 of the gallbladder. Perforation is again important, and the way you pick up a perforation is to show that there's pericholecystic fluid already. There are patterns which Callan gives you, Takada et al., and we will see a few of this. That's a gallbladder, that's pericholecystic fluid collection. That's a small abscess happening over there. That's a gallbladder, and that's extensive pericholecystic fluid. That means there has been perforation somewhere. That's perforation, again pericholecystic. When there is perforation, the gallbladder which was dilated collapses. That's a pericholecystic collection. The gas echoes over there in the collection. This gallbladder has collapsed in spite of an impacted stone. So a gallbladder which is collapsed in spite of an impacted stone, one must be sensitized to perforation. Chronic cholecystitis, we did the WES sign versus porcelain gallbladder. Gallbladder thickening could be, wall thickening could be diffuse or focal. Remember, diffuse thickening is not due to GB disease, whereas focal thickening is due to GB disease. Focal thickening we'll finish first. How much time do I have? Can you just tell me when it's 5 minutes more?
We have 10 minutes more.
10 minutes, that's great. Okay, focal gallbladder wall thickening could be due to polyps, could be due to carcinoma, adenomyomatosis, AIDS cholangitis, gangrenous cholecystitis, metastases in the gallbladder. Now, gallbladder polyps are important because they are common lesions, and having picked up a polyp, what are we going to do next? The patient is going to be worried. We need to tell the clinicians and the patients as to what is the game plan now. So the polyps could be inflammatory, could be cholesterol, could be adenomatous polyps. They are small or medium-sized. It is an intraluminal echogenic focus, mural adherence, no shadowing. So polyps have no shadowing and they are stuck to the wall. Adenomata could be sessile or pedunculated. Differential diagnosis, tumor factor sludge or ball-like sludge. Now these are small polypi sticking to the non-dependent wall, multiple polypi over there. These are multiple polypi. You can do a 3D rendering, surface rendering, showing all those little small polypi sitting in the gallbladder. Some of the polypi can give rise to a typical comet-tailed artifact, which tells us that they are possibly a cholesterol polyp. This was the other polyp we saw in the 71-year-old over there. It's a broad-based polyp. It's a sessile polyp, so I'm worried about it being an adenomatous polyp. But this old lady says, I'm not going to get surgery done. I'll come back to you year after year. You measure it out for me. Okay, now what is the game plan? If a polyp is less than 5 millimeters in size, no further workup. If it's 5 to 10 millimeters in size, periodical follow-up. You can do a 6-monthly or 3-monthly if the patient is too worried. And if it's more than 10 millimeter size, we don't take chances. You advise or you opt for a removal of the gallbladder. Okay, this we saw how to differentiate between sludge and thing. We go on to adenomyomatosis. It is a non-inflammatory condition. Wall thickening could be segmental, and it opts to thicken out at the fundic level, at the fundic area. Wall is hyperechoic. Discrete comet-tailed artifacts arise from the Rokitansky, Askoff sinuses, which house the cholesterol. crystals there, and then of course there could be an associated gallstone. Now look at the gallbladder here. That is the neck, that's the neck. The neck region, the wall is not thick, but the fundic region, the wall is definitely thick, and then you have the little small comet-tailed artifacts, and there's an associated gallstone there. Again, typical fundic and distal half involvement. Proximal half of the gallbladder is free of disease. The wall is normal. And this is stones again plus multiple comet-tailed artifacts. So all these are adenomyomatosis. GBCA is a devilish condition. It is highly malignant, early metastasis, downhill course, female predominance, stones in 80 to 90% of cases, and chronic cholecystitis and porcelain gallbladder actually predisposed to GBCA, and only 30, that's the sad part of the story, only 30% of GBCAs are detected early. Most often they present to us only after infiltration into the porta hepatis. They come with obstructive jaundice. Okay, the types are fungating type. These are very crude diagrams I just draw a few days ago. Please pardon me, but it gives you a good idea of what the types are. That's a fungating kind of a polyp which has an irregular border there. Then you can have the diffuse wall thickening or the flat indurating types, and then you have a huge mass there with very irregular border, a very aggressive looking tumor with stones entrapped within. Because most of these gallstones...
You have 5 minutes more.
I have 5 minutes, thank you. Most of these carcinomata develop on the background of stones, and as the mass forms, the stones are actually entombed within the mass, entrapped within the mass. So we'll try and look at some images. So let's look at this particular gallbladder. It's full of an ecogenic area over here. Is it sludge or is it mass? Color Doppler helps us. You have tissue or you have vascular signals over there. So I'm very, very worried about this particular. It's a large polyp, and therefore I'm worried. Again, a gallbladder which is filled over here with a mass. Filled over here with a mass. I'm worried about this. Now let's look at this gallbladder. That's a gallbladder which is a little dilated, but when I come to the neck, there is thickening of the neck out there. The whole neck is thickened out. There is stasis in the gallbladder. There's also a bile sludge level happening over there. When I turn the color Doppler on, there is vascularity, hypervascularity in this thickened region. Again, that really puts me on guard. On the other hand, let's look at this gallbladder. The neck region looks okay, but the fundic region is grossly thick. And whenever there is a non-diffuse or focal gallbladder wall thickening involving a part of the gallbladder sparing the rest, one must be wary. And when I do a color Doppler, there is vascular signals coming up from this thickened area. Again, a gallbladder mass over there. There's a stone, there's a gallbladder mass there, and there is an empyema which is developed distal to the CA. Now this is again a mass there. That's the residual gallbladder lumen. That's the gallstone there. That's the gallstone. Actually, the gallstone here gave way to the gallbladder origin. Now what's important is that the mass merges imperceptibly with the liver. Therefore, we know that it's infiltrated into the liver bed. Not only that, there is porta hepatis, lymph, adenopathy, and what is compressed? The portal vein is compressed, and that's the color Doppler or the power Doppler of the portal vein. That's the mass again showing neoangiogenesis. That is the tumor vascularity of the GB lesion. Diffuse is oftentimes non-inflammatory. It could occur. I'll just finish with this and we will stop. I still have time. Okay. So we talk of wall thickening if the wall is equal to or greater than 4 millimeters. It could be inflammatory as in acute cholecystitis, chronic cholecystitis, sclerosing cholangitis, AIDS or Crohn's. So that is diffuse wall thickening happening there. That is again a wall thickening which is happening over here around the gallbladder, and all along the porta hepatis and the portal vein divisions you find a lot of infiltration and hyperechogenicity which is happening. So I thought it was really an AIDS cholangitis. I went into the records, but this patient was HIV negative. You see all these, the periportal infiltration pathology so well brought out, and plus of course there were juxta-aortic nodes in this particular case. Diffuse non-inflammatory. So diffuse wall thickening, you classify it into gallbladder inflammatory and non-inflammatory, and non-inflammatory is much more commoner than inflammatory. So you can get gallbladder wall thickening as a part of hepatitis, cirrhosis, hemorrhagic fever, CSF, so on and so forth. We will just see a few of them, and of course not to forget physiological contraction. Here is a small contracted gallbladder, and when the gallbladder physiologically contracts and pushes the bile out, its walls become thickened out, and that's not pathological. Call the patient back again on an overnight fast. It's all opened up now. Now here is a liver which is enlarged. Patient is jaundiced, so we know it's hepatocellular problem, and you look at the gallbladder wall, it's thick. So gallbladder wall can thicken secondary to hepatic dysfunction, and when you do a high frequency assessment, you see typical striations. Or striated gallbladder wall doesn't mean it's gangrenous. It doesn't mean that it's a specific etiology. It's just that sometimes there are striations, no special significance there. Oh, what happened to this? I don't know. Okay, now here is a hepatomegaly, jaundice. This is a case of melanoma on chemotherapy, and because of the hepatotoxicity, the gallbladder wall has thickened out. So it could be due to hypoalbuminemia, which it occurs. There is in fact an article which says, in a case of ascites, if the gallbladder wall is less than 4 millimeters, think of the fluid as a transudate, as being secondary to cirrhosis, whereas if it is less than 3 millimeters, think of malignant ascites. So malignant ascites, the gallbladder wall doesn't thicken, but in ascites due to hepatic dysfunction, due to hypoalbuminemia, as occurs in cirrhosis, you will have a gallbladder wall thickening. Okay, those are a few examples. Okay, gallbladder wall thickening can also be due to, can also be due to gallbladder wall collaterals. So in cases of portal hypertension, you can have gallbladder wall collaterals which are seen as real small, tiny little foci, and when you turn the color Doppler on, you will find each of them filling up with color. Can you see the small little vascular structures? So they are all gallbladder varices, and when you turn the color on, each of them fills up with venous flow. Abnormal contents, can I finish this? Just give me 2 minutes. Sludge, artifacts, milk of calcium bile, parasites, blood, pus, membrane, so on and so forth. Sludge is due to bile stasis, and it could be due to obstruction to the drainage of the gallbladder, or it could be just that this patient is on hyperalimentation and this gallbladder is not getting the stimulus of fatty diet for it to contract, and therefore it just builds up atony and it has stasis. Dependent position of the sludge, no shadowing, clear bile sludge level, tumefactive, and it could be artifactual. Sludge is composed of calcium bilirubinate and cholesterol crystals. This is a sludge in the gallbladder secondary to the case we saw before, CBD calculus. This is again sludge in the gallbladder. It could be really ecogenic, but remember, sludge doesn't shadow at all. That is sludge again, no shadow there. This is sludge filling up the gallbladder. This is artifactual sludge. If you cut through a part of the gallbladder, you will actually create artifactual sludge over there. Now let's look at this here. Can you see the sludge-like material there? But when I do a straight bang-on center image of the gallbladder, the sludge disappears. So if I cut a part of the gallbladder wall and the rest of the beam goes through outside the gallbladder, that partial volume effect can come here. Which is the other artifact which can give rise to echoes within the gallbladder? The side lobe artifact, otherwise known as the grating artifact. This, of course, is a ascaris, adult ascaris in the gallbladder. When you see very, very echogenic contents uniformly flooding the gallbladder like this, that could be blood in the gallbladder. Luminal bleed, non-visualized gallbladder, we just did this in the other presentation. Laparoscopy and gallbladder, yes, the size of stones are important. Whether the duct is dilated and whether the calculi are there are important. A large gallstone means an umbilical incision. The port through which the stone comes out is larger, and other serendipitous pathology might modify the approach. The length of cystic duct and aberrant cystic artery are things often asked by the surgeon, but ultrasound may not be able to provide the answers. But what ultrasound can do is to sort out postoperative complications in terms of hematoma in the abdominal wall, a biloma, an abscess, CBD, ligation, so on and so forth. So that's a huge biloma secondary to a lesser sac biloma secondary to lap coli. This is a parietal hematoma secondary to laparoscopic surgery, and therefore we can sort out per-op and post-op situations. So some hints are harmonics clear up artifacts, prone position brings out stones to the fundus, always examine biliary ductal system, focal zone adjustment for stone shadow, scan after fat abstention, important for gallbladder non-visualization. Pitfalls, true neck versus false neck of the gallbladder. Only structural assessment, we can't assess the function of the gallbladder. Hypersthenic patient habitus can give us problems. Stone versus pyloroduodenal gas, we've learned how to get out of it. So ultrasound has supplanted all other imaging modalities in assessing the gallbladder in health and disease. A variety of local pathologies can be well documented by ultrasound. GB reflects systemic pathology in certain conditions. It plays a role in surgical planning and in evaluation of post-op complications. Thank you very, very much for a very patient listening. And thank you, everybody. I've had a wonderful time. Thanks to Dr. Nusha in particular, and thanks to the entire department of University Malaya Medical Center, Department of Radiology. Thank you very, very much.